this is a huge problem to certain athletes to suffer from a stress fracture or bone stress injury. And then I invite you to count how many times I said stress fractures instead of bone stress injury. That is the new terminology that we want to use. But anyway, if you suffer from a bone stress injury and you are a top level athlete, you are in trouble. And we can refer back to Kelly Holmes, that she was a double Olympic champion 800, 1500 meters in Athens, 2004. And when she was interviewed by our colleague Paul Destra in the Aspetar Sports Medicine Journal, edited by our friend Nivo here present, she said that in the first Olympic appearance in Atlanta, 96, she suffered from an eagle just in front of her leg, and she confirmed that she got a stress fracture, a bone stress injury, and her Olympic expectations were literally busted. But she was able to recover. And this is one of the things that we need to talk about, is the importance of the bone stress injuries in sport, because the athletes sometimes suffer for this in a very difficult moments. It's a long time loss or very long return to play, and it's relatively common, and it's probably one of the most common overuse injuries. Up to 10% of the literature says it could be a bone stress injury. So I will go around all the topic by this outline, and I highlighted in bold the 3 areas that I would like you to bring home at the end of this presentation. I like you to learn what is a bone stress injury, a high-risk bone stress injury, where they are located, and have a rough idea what is the best management to do. The definition is a very wide one, so we can say that the bone stress injury goes from a little bit of periostitis, a term that is not very used in English, but we use a lot, for instance, in Spanish, in French. And it goes from that, a little bit of bone stress around the outer layer of the bone, then develops more and more to the marrow edema, or more and more edema, and ends up with a fracture. And this is a long and a wide continuum. It's important to differentiate, again, between bone stress injury and stress fracture. And I invite you to read this very interesting editorial last December in British Journal of Sport Medicine, insisting that not all the bone stress injuries are stress fractures. So there is a concept that is not yet proven, but we use a lot, is this bone stress injury continuum. And we go from the far left with a little bit of normal remodeling. If there is a lot of load, or the load are in very short period of time, very repetitive, there can be an accelerated remodeling. If the load keeps going, then we start to have stress reaction, a term that some of us we discussed. We are not happy with the stress reaction term, but we can say there is a little bit of bone stress from grade 1 to grade 2 to grade 4. We will discuss about this later. And then we end up with a fracture. So it's very interesting to see this evolving problem from a little bit of accelerated remodeling to the full stress fracture. The epidemiology of the bone stress injury is, let's say, it is well published. And we can say that, first of all, in Olympics, surprisingly, up to 8% of all the injuries are bone stress injuries. That any athlete in any team, mainly individual teams, can suffer from 1 to 2 bone stress injury each year. That is very common in athletics. I will show you some statistics. Again, sorry, my sport is leading the way here, not for good, precisely. It's very common in female, and obviously it's much more common in lower limb. Although today it's very common to see locations in the upper body like humerus, rib, or even the other areas like clavicle. So it's very interesting, the evolution of the statistics. Remember that the return to play is long, that the average could be around 12 weeks, and 1 out of 5 of each injury means the end of the season, which is very important and has a huge burden on the athletes. So For instance, talking about Olympics, Rio de Janeiro statistics. We don't have yet the statistics of Tokyo published, but in Rio de Janeiro, you can see that athletics means around 44% of all the bone stress injuries. Then you have other sports like volleyball, gymnastics, but athletics alone, 11 bone stress injury, 44% of all the Olympic bone stress injuries. And we look at the National College Athletics Association in the US university sport, we see again, and we can zoom indoor track, outdoor track, and cross country, the three disciplines of athletics, the three of them together sum up by far the more important incidents. But also it's interesting to see this graphic, to see also gymnastics, basketball, and tennis, soccer, or football, lacrosse. So anyway, as you can see in university, college sport, bone stress injury are quite common. Athletics, again, is leading the way. Talking about a little bit of physiopathology, I don't want to enter in this much because I can dedicate the full presentation about this, but retain this concept of repetitive loads in a very short time of a period of time. That means that the bone is forced to do a huge effort in remodeling, and sometimes that effort is a failure because the loads are so important and so close in time that the bone is unable to repair. And then is when we have an injury. And this is a very interesting graphic to show this. Talking about the risk factors, again, there is possibility to talk about this 1 hour, but I will summarize in 4 concepts. First, apparently being female, white Caucasian, non-Hispanic is a good risk factor. So some of you are unfortunately now, just by sitting there, being a risk factor of having a bone stress injury. History of previous bone stress injury, and this is not a surprise because a risk factor for pretty much any musculoskeletal injury is having a previous injury as a history. A recent increase in the load, and this is very common, and or a surface change. And then a concept that probably has been introduced recently in our minds. 20 years ago, we didn't talk much about this. 20 years ago, we were talking about the athlete female triad, but now we are talking about low energy availability, or what is this new concept that I like, the restricted energy diet in a sport. So let's talk about a little bit the concept of high risk bone stress injury. And I would like to invite you to join me in this historic journey because it's a very interesting concept that has been evolving in time. We need to go back to 1965, almost 60 years ago, when this orthopedic surgeon from England, Mr. Deva, he published this paper, a very interesting paper only talking about femoral neck. But it was the first time that somebody said that in the femur neck, there is 2 areas of potential problems when we are talking about location of the stress fractures. Again, stress fractures, the bone stress injuries. So he said that there are a compression side and transverse side that is the opposite side. I will show you where is this located. And he said that these transverse stress fractures have a tendency to evolve and become displaced. This is 65. Sometime later, in 88, these 2 authors published another paper talking again about femoral stress in the neck, femur neck stress fractures, and again this concept came along again. So compression side, the side, or tension side, that is the opposite. And I will elaborate this a little bit more. So retain this because this is 88. Then this book, that is a very interesting book that Dr. Paul and myself probably bought in 2000, just 1 year after it was published. And Peter Bruckner, one of the most renowned sport medicine doctors from Australia, he wrote this paper together with other authors. And he came again with the concept of tension side and compression side in the femur. And this probably is the most important paper on this history journey of what is a high-risk fracture. So these 2 authors in 2000, Voden and Osbart, they say that the high-risk stress fractures have a predilection to progress into complete fracture, delayed union, non-union, and they are difficult or very difficult to treat. And they, for the first time, they elaborate a list of potential situations or locations in the body, and they quote for the first time the femur neck, the patella, the anterior cortex of tibia, tarsal navicular, the fifth metatarsal, and we will visit this again in the future, in the next couple of slides. So in 2005, another important author in bone stress injury, Kidding, he said more or less the same, that, by the way, he made a reference to the Bowden paper and talked about tension and compression, and he described the complications of this fracture. So this could be a complete fracture, non-union, recurrence of the fracture, etc. And in 2016, these two Bostonian physical medicine and rehabilitator doctors published this very interesting, it's a narrative review, but it's very good. And they describe what it is important for them, what is the concept of high-risk fracture. And is these two problems, or an area of increased tensile load, or an region that is poor blood supply in the bone. This is the two main aspects or features of the high-risk injuries. And then they say that more or less, as we say in the previous slides, that there is a risk of poor healing with complications like risk of non-union, prolonged time to sport, out of sport, etc. So again, remember, in the femur neck, compression side is kind of the less risky area. I cannot say it's safe, but it's less risky. But definitely, if you go to the tension side, this is where we are having a high-risk problem, a high-risk injury, because this can open and then ends up in a more important fracture or a delayed union fracture. So the next slide is one of those slides that I would like you to retain at the end of today. So remember, please, how or what is a high-risk injury? Is an injury located or on an area of maximal tensile load and an area of diminished flow. And this determines all the other features. So we will have a poor natural history. They will be low return to play. They can evolve into complications like non-union, delayed union, complicated vascular necrosis, etc. And we will discuss about this at the end of the talk. The important thing is that sometimes they need very strict non-wavering or surgery. I will elaborate this more. An example of tensile side. It is the anatomy of the tibia. It's like this. The anterior part is a tension area, and the posterior side is a compression area. This is an example of what is a high-risk location. And next slide, another one that I would like you to retain. So remember, these are the most important locations. Actually, these are all the locations of the high-risk bone stress injury. So the most important one, probably I highlighted in red, the three more important that are the femur neck in the tensile side, the tarsal navicular, and the anterior medial, anterior medial border in the tibia, because the posterior, I'm getting confused now. So posterior medial is the safest, is the low risk, and anterior lateral is the one that is high risk. But we have other locations like patella, medial tibial plateau, in the upper body only olecranon, and the ulna and pars interarticularis, in the vertebrae, and important also to remember the medial malleolus, the talus, and the metatarsal, second and five, and also sesamoids are location of high risk. So I will show you this again in the next slides. Why tarsal navicular is a high risk location? Well, see the very poor blood supply of the central area of the bone. So this bone has two arteries, one in the plantar side, the posterior tibial, and one in the dorsal side, the dorsalis pedis. But they give, this one gives the blood supply to the lateral side, and in this for the medial, but just in the center part of the bone, there is an area that is very poor blood supply. And most of the times, the bone stress injuries are all around the bone, but the stress fractures are just in this area. So remember, this is a good example why we are saying that high-risk location is because of poor blood supply. So, talking about the main features of a bone stress injury. Pain is the thing that you need to remember. And the pain can come for a little bit of pain when they start to train very hard, to a pain that goes even more severe and starts to bother the athlete during the training session. Sometimes the pain stops when the workout ceased, but sometimes the pain keeps on going after the workout. The pain can come on night. The pain can come on the following morning when they wake up. And all these features can make you think that you are in front of a bone stress injury, and maybe it's an important one, because when the pain is even forcing the athlete to stop their workout, is because it's an important injury. So obviously some of these different areas that we define as high risk bone stress injuries could have specific features of how the pain is presenting. Remember probably that the femur neck is difficult to differentiate, it's difficult to think about it. But if you have an athlete with a pain on the groin area, on the hip area, that sometimes is referred to buttock, sometimes is referred to the knee even. So this could be a little bit of suspicious, and think about the femur neck as a possible location of the injury. Then it's kind of easy to think about an injury on the patella if you have anterior knee pain, but I understand that anterior knee pain can also come from patella tendinopathy, patellofemoral chondropathy, etc. But think about this. Medial plateau is also difficult to think about it because we think another injuries, but if you are again in front of somebody that had recently an increase in the load, and you have any of the pain with these locations, think in bone stress injury, because the most important thing to diagnose the bone stress injury is to think about it, to have a high index of suspicion. So these are the main features, diagnostic features of the bone stress injury. So you have first a localized tenderness over a bony location. There is a history of recent change on training, or an increase, or maybe just changing the surface or starting a new activity, and an abnormal signal in MRI. I place in orange the normal appearance in X-ray, because we tend to do less X-rays today because MRI is kind of the golden standard for the diagnosis. I'm not discouraging you to do X-rays because you might need it, or pretty much always. You need to be sure that there is not a fracture. But if you don't do it, maybe you won't see that there is most of the times normal appearance. But sometimes you find fractures. Then, what is the main aspect in the physical examination you can do? Well, there is two things you can do. Is either palpate directly the bony tenderness area, or make a kind of a loading test in the bone. So, kind of easy in a superficial bone. So you have the tarsal navicular, remember what is called the N spot. You can palpate in the dorsal medial aspect of the foot. This is kind of easy. You have the pain on the anterior tibia or the patella. You can palpate the pain. But you cannot palpate the pain in the femur. So what you can do? You can do this thing, the hopping test. With the hopping test probably is the most reliable one. It's good for you to help you with the diagnosis. It's very good for you to do it during the follow-up, because you will see that the pain at the beginning could be both hopping with two legs or hopping with one leg. And some of the times the pain starts to evolve that is not painful in the two legs hopping and only hopping with one leg. And then at the end, after 6 or 8 or 10 weeks, you will see that both with two or one leg, the hopping test is negative. Another test you can do, for instance, this is a low-risk location, the calcaneal bone, but doing this squeeze test helps you to suspect that you have a calcaneal bone stress injury. If you have a suspicious of femur shaft, well, this is a recent description early this year, how to do what is called the fulcrum test. There are other ways, but this is a funny and very illustrative pictures that you can do. Fulcrum maneuvers, anterior to posterior, posterior to anterior, medial to lateral, or lateral to medial. This is one of the things you can do, fulcrum test for the femur shaft. And then what is the vibrating fork? the vibrating force, you probably, you see me on consultations, I always bring in my vibrating force. I forget, I should have bring it. So it's a very interesting thing to do. This can help you to suspect the diagnosis, and also is very useful in the follow-up. But their evidence is debatable. So there is a recent paper, not that recent, it's almost 9 years ago, that they said that there is no strong evidence to use it, but clinically it could have a use. And you are in remote areas, or you are with a team in an area that you don't have X-rays on hand, and you are doing a training camp, whatever, imagine in the mountains, maybe wearing a tuning fork with you in your medical bag is an interesting thing to do. And I like to use it. Then one of the most important aspects when you are dealing with the bone stress injury is to come with a diagnosis, to have a grade of the intensity of severity of the injury, and for that we use use MRI, the magnetic resonance. And there is a lot of classifications. I think it's around 25 different classifications for the bone stress injury. But we use one that is called Frederickson, because this author Frederickson in the 98 or 99, he published a very interesting paper classifying the injuries, coming from no abnormality in the signal to a little bit of abnormality in signal in T2 to more abnormality, then both T2 and T1, and then the highest grades are when you are in front of a severe bone stress or bone abnormality in the signal, and this is called grade 4A, or when there is a line on the bone MRI, and this is 4B. This is a modification made by Kijowski, and in agreement with the radiologists, and here present we have the chief radiologist, Marcelo, we agreed that this is the classification we are going to use almost always in Aspetar. So remember, the Frederickson modified Kijowski, and it's a very interesting thing. Just one link between the grade to the return to play. This is a very interesting systematic review that I did a journal club last August in 2022. So this systematic review gathered around 26 different studies, 500 bone stress injuries, and they came to the conclusion, and they used the old Frederickson classification, that if you have a grade 1 injury, more or less the return to play will be around 40 days. Grade 2 means 70, grade 3 means 84, and grade 4, that in the Frederickson all one means there is a line of fracture, is around 100 days of return to play. So very long return to play, and this is linked to the grade, and this is important for you, and I will explain you why, because the risk stratification for your management of the injuries is very much based on the grade in the MRI, sorry. So this is a personal algorithm that I came to develop, and obviously you can criticize it. There are other more complex algorithms in the literature published. This is not proven, but for me it's good. So first of all, the most important thing, you need to suspect the injury, to do a good clinical examination and history, and request the MRI. And with the MRI, you will have a grade. And that grade, together with the location, you will have high risk or low risk location. It will come to a specific management plan that I will talk about that now. Before we go to the management plans, remember the locations of the high risk injuries. And I have a particular interest for you to retain this slide, because this is very important. And remember that we have olecranon and the pars interarticularis as the upper body locations, very easy. Not other location is considered high risk. And then from the hip down, remember femur neck on the tensile side, patella, medial tibial plateau, anterior tibia, medial malleolus, talus, tarsal navicular, second and fifth metatarsal sesamoids. This is very important, remember. So, what is the management? Probably the most important slides before we conclude. First of all, you need to consider and decide to do an activity modification for the athlete. You need to develop a strategy what to do if you are going to go to a conservative treatment, or you need to do surgical treatment from the early stages. Progressive loading, and you need to discuss how you will stimulate the bone to heal from the early stages when you can. And obviously, very important also, from the very preliminary moments, you need to investigate what are the risk factors and try to modify them when they are modifiable. And then when you have the more or less ready, start to have a return to run or return to activity plan that allows you to get the full recovery and trying to get the athlete ready as soon as possible. So remember, very important, we are talking about areas that can progress to complete fracture, to delayed union, areas that there are very poor blood supply. So you need to be a little bit conservative. Although some of the authors, when you read the papers, they consider this aggressive. But anyway, if it is conservative or aggressive, the important concept is you need to consider most of the time when you are in front of a bone stress injury located on the lower limb is you need a non-wavering cast 6 weeks. And this is kind of a rule of thumb. And consider this and remember this. Then we can discuss in the question and answer later about the particularities of this concept. But for me, it's important for you to understand that we are in front of difficult injuries to treat. And it's better to be conservative from very early stages to avoid complications and difficulties. Then, obviously, surgery could be decided very early. You have a fracture in the femur neck. And in the femur neck fracture, stress fracture, is more than 50% of the neck. For sure, that's a surgical indication. When is less than 50% of the neck, there is a doubt to do or not surgery. If you have a fracture line in certain areas, like the navicular bone, also is another indication for surgery. If there is a displaced surgery, or for instance, you are in front of a high-level athlete that has a tarsal-navicular location, probably with a very tiny little fracture, you can decide to do surgery because it's a high-level athlete, you need to secure an appropriate healing. And obviously, you try non-operative and it's failing, you most likely need to do surgery. So every location has a particularity. So I will just refer to 3 of them because otherwise we don't have enough time. So remember, femur neck. Again, if there is a tension site, probably you might need surgery, or at least you have to be very conservative. There is a specific classification for the femur neck in addition to the Frederickson-Kijowski, and there is not only one, there is at least 3 that I am aware that classify the bone neck, the femur neck, depending on how much is involved or displaced. So it's important to understand that. But I think, again, if you are with a high-level sport, imagine a football player, very weird that you will have a male football player with a femur neck injury. It's not impossible, but you might need to decide surgery from early stages. Otherwise, if there is no big lining fracture, you need to be conservative, put on non-wavering crutches. Obviously, you cannot cast the pelvis, but you can do other conservative approaches. Then remember also the anterior tibia. I didn't mention, but there is an image that some of you probably had in mind. That is this dead spot in the anterior side of the tibia. And when you have that, also you have to remember that you have to do the differential diagnosis with osteoma osteoid. But it's important that anterior tibia requires 6 to 8 weeks of non-wavering. Crutches, you can decide cast or not because that area is more difficult to immobilize. And again, probably there is a systematic review published in 2017 by a group of Dutch people that recommend from early stages to do open reduction and internal fixation. And then the doubt with that particular stress fractures is whether you go to an intramedullary nail or plates and screws. But this is an area that we are not that sure so far, but I would recommend you be very conservative with the anterior tibia. And then probably the most difficult one to treat, at least in my experience, that is tarsal navicular. And with tarsal navicular, you shouldn't hesitate a single second to put anybody on a on a cast 6 weeks. And this is published, and it's published on and on. And there is no information saying otherwise. We can come to studies made by Peter Brackner and Karin Kahn, that has been here, the scientific director in Aspetar some years back. They published in 98 a series of 200 fractures of tarsal navicular, and they came to the conclusion that novovirin is the most important treatment. The same with an author that is called amoxicillin that published a lot, and say again 6 weeks of novovirin. And I am talking mainly when there is bone stress injury, when you don't see a line of fracture. When there is a line of fracture, it's a completely different beast, and probably you need to do from the early stages surgery. And there is another classification made by Saxena that classify the bone in 3, depending if it is the line is 30%, 60%, or 30%. He says type 1, 2, 3. Type 1, probably you can maybe be saying, okay, let's do novovirin, but if you have a tarsal navicular stress fracture, classified grade 4B in Frederickson Kiyoski with type 2 or 3 on the other classification, no doubt, you need to go to surgery. And I can come to recommend here a systematic review published in 2021 by our Chief Medical Officer, Peter Dug, and he and his group said very clearly that the best return to play in tarsal navicular fractures, stress fractures, is surgery, no doubt about that. So remember these 3 areas because are the most common, the more difficult to treat, and we can go to other areas if we have time later. Remember that the management is not only putting in casts and surgery, that is the most important aspect to discuss, but also you need to consider the active modification, the physical fitness of the athlete, you have to keep it, and to identify the risk factors from early stages and start to treat them. And the return to activity needs a plan. So you need to plan when the athlete is able to walk, when is able to walk faster, when he start to jog, etc. And you can use several strategies. Alter G is a good one. Aqua running is a very good one. Cross training is very important. And an important concept that I would like also to highlight, that is this last one, the running or gait retraining that our podiatrists love, that is teach the athlete to run again from day 0 after the injury, because sometimes they are doing kind of faulty biomechanics when they run. And if they modify certain aspects of the running biomechanics, they can reduce the risk to further injuries. We can talk about other therapies. Yesterday we have a very interesting journal club about extracorporeal shock wave therapy. There are more evidences that suggest us to use this in bone stress injury. Still there is no big systematic review in the literature to convince us that we should use it, but I recommend you to consider in certain cases. The use of recombinant parathyroid hormone is questionable. There is no, to my knowledge, it's only 2 papers published, and one of them is a series of 14 people. So I don't think we have enough evidence to start using teriparatide. But if you are in front of somebody that has proven low bone mineral density on DEXA scan with osteoporosis -1 set score, probably you can decide to do teriparatide. By the way, not yet available here in Aspetar, but we are working together with the pharmaceutical department to get approval to use this only when we are in front of proven osteoporosis or osteopenia. To my knowledge, there is no role for the use of PRPs in bone stress injury, unless anybody of you know the contrary, and please tell me if this is your case. And I would like you, again, to bring the concept of the long return to play to your mind. So this is a systematic review published in January. It's an impressive systematic review, 70-something studies, 2,000 bone stress injury cases. I recommend you to read it. I will present the journal club in April about this paper, I think in 4th April. So if you are interested in this topic, come to listen to me again if I am not getting bored you today. And I will talk about this topic again. So interesting, this association. So tarsal navicular has an average of return to play of 4 months, 127 days. Very important. Then we have the femur occasion, is around 3 months and something, 100 days. And the medial malleolus in this systematic review, they say they're talking about 106 days. So remember that the high-risk locations mean long return to play. And we already said the same talking about the grades. So when we are grades MRIs, grade 3 or grade 4, and we have high-risk location, expect 3 to 4 months, and you need to tell the athletes. And you can use this systematic review to teach the athlete. You have this location, tarsal navicular. The scientific literature says that you have to wait more or less 4 weeks, 4 months. Be ready to that. We will help you, but be ready to that. Important concept is the return to activity. I would like you to show you 2 studies that show a little bit how you can do the progression. The important thing is you need to remember that you are starting in walking and you need to end up running. And to do so, you need more or less 4 weeks, starting with a little bit of walking, and ending up in jogging and more jogging, and you end up in running. Remember the concept that probably 1 day on, 1 day off, 1 day rest after each stimuli. And then important to start walking very short and slow and end up running fast. This is one way. Another way, and this is published recently, it's a very interesting publication in military recruits, doing 2 stimuli per day, 1 in the morning and 1 in the afternoon, but always with a 1 rest day. Again, 1 day on, 1 day off, starting with a little bit of walking, ending up with a good running. And again, it's 3 phases, and important the concept, of the progression, okay? Then, I would like you quickly to visit a case report that I would like to show you, to show how we approach the athletes in this hospital. This is a basketball player, 70 years old, 2 meters high, only 78 kilos. The BMI is a little bit low, only 19. He has been training hard the last days because he had previously 1 month off because there was something called the FIFA World Cup and his school was closed and he couldn't train at all. He says that he has a pain in the midfoot, a diffuse pain, difficult to locate. And the pain yesterday made him stop training because it was very severe. But he said that in the previous weeks, the pain has been gradually increasing. And at the beginning, it was only training, then also at night. But yesterday, unable to walk. We do the physical examination. So remember, this is a bone that we can palpate. Any spot is painful. Still, we do the loading on the bone and the hopping test, also positive. And Dr. Juan-Manuel Alonso, this crazy guy that goes with his vibrating fork, makes the vibrating fork test and is also positive. Okay, so what you will do first? Please, anybody, volunteer. What will be the first thing you will ask now? MRI, right? So this is the MRI. It's an MRI that probably is grade 4 for A. There is a suspicion maybe online, but I'm not clear. So let's see the other sequences. So I think this is grade 3, more grade 4. Marcelo, do you agree with me? I think it's grade 4. Okay. So important with the navicular. At this stage, you better be sure that you are not in front of a fracture. So what you do, you request CT scan. So the CT scan, this would be a negative one. But I will show you how is the positive CT scan in a bone stress in the navicular. This is a navicular, tarsal navicular bone stress injury, stress fracture. Very clear. Okay, so remember, tarsal navicular, do a CT scan on top of the MRI because you might need it. So, what's next? What do you need to do? We have been talking about. So, I think this is clear, or is anybody that has anything against this recommendation? To do immediately, remember it's a grade 4, no fracture. Huh? We said we did the CT scan and the CT scan is negative. So we are in front of a big grade, but it's still no fracture. So my recommendation, 6 weeks, no weight bearing and cast. Then, early stages, we ask for risk factors. So we refer the guy to the blood phlebotomist to get the blood work. And we are looking for vitamin D, calcium, iron metabolism, and also at the same time, we refer the guy to the nutritionist and ask the nutritionist to check the energy intake, the protein intake, all that things, and probably she will consider to request for a bone scan, bone mineral density to check whether there is any osteoporosis or not. We will send the guy to the podiatry assessment, although we will say, okay, hold on a minute, because now you are on a cast. You cannot go to the podiatrist, but you will be going to the podiatrist in 6-8 weeks after now, because you will need it. And then, if he is a high-level athlete, his growth plates are already fused and closed, you might consider with therapy, and then you need to revisit if you are using a cast or not, but we can discuss that later. And then, important also, the rehab program probably is the moment to, well, first keep the fitness, then consider if the guy has any muscle weakness or disbalance to address that. To use maybe bone stimulator. Here is use both the low impulse ultrasound or bone stimulator, but this is a discussion we can have later. And very important to have a plan for return to run or jumping, as I showed you in the previous slides. Remember the guide retraining, and this is pretty much what we can do in front of a case. And this is what we are doing now in Aspetar. So remember, have a high index of suspicion for all these injuries, that there is always a long return to play, that the location plus the grading determines your risk stratification and then the specific management you will need. Remember this thing of no wavering cast 6 weeks is a rule of thumb. It's not proven, but it's a kind of safe rule for all of you. Maybe we need surgery from early in the beginning, and very, very, very important, risk factors management. This is, for me, the take home you need to bring to your houses. Remember what is a high-risk location and why. Remember the locations, and please, if you have any doubt, don't hesitate. Put on a no wavering and refer to us, to the people that we like to deal with these cases, because we will be happy to treat. We have a bone stress injury group in the hospital working since March 2022. Some of the members are here in the room and probably most likely online. And remember that any of us, Dr. Aston, Dr. Steve, or myself, we will be happy to accept referrals for any of you.